So it's a common colonizer, and under normal condition, it behaves as a commensal organism without really causing a disease. Even in a normal individual, it is found in half of the patients or healthy humans on the mucosal membranes. So we very frequently would see it in superficial cultures, BAL cultures, sputums, urine culture. So if you have a non-sterile specimen, right, Candida will be very frequently isolated. And one of the roles of the infectious disease physician is to tell, non-ID provider that this is not your problem, right? And you do not have to treat it. So again, look specifically where this was isolated. There are three major conditions that puts you at risk for human invasive infection or invasive candidiasis. The first one is a long-term and or repeated use of broad spectrum antibiotics, and that leads to increased Candida gut colonization and puts you at risk for translocation in the patients that are on immunosuppression, long-term steroids, and also another very important factor that puts you at risk for human invasive infection is a breach of GI and cutaneous barriers, and we'll talk about it in details in a few minutes. So just a reminder that yeast multiplies by budding, and all Candida species except Candida glabrata form pseudohyphae in tissue. And in the right lower corner, you can see how the hyphae would look in the tissue. But again, remember, all of them except Candida glabrata. And briefly about the epidemiology. So we'll talk about the distribution of species. Candida albicans still remains the most prevalent species, which is associated with invasive candidiasis throughout the world. However, the distribution of non-Candida albicans species depends on a few factors. It depends what part of the world you are, what part of the country you are, and what healthcare facility you are currently evaluating. So the distribution of the non-Candida albicans species will be different depending if you're at the cancer center, if you're at the LTAC, acute care hospital, and so forth. So this is a map that specifically looked at the distribution of non-albicans species throughout the world. And as you can see on the left, specifically for the United States, Candida glabrata was the second most common isolate. This paper is a few years old, but it still remains the second most common. And if you look at the other portions of the world, you can see that Candida parapsilosis, Candida tropicalis might be much more prevalent than Candida glabrata, comparing to the United States. One of the major virulent factors of Candida infection is a biofilm formation, right? So that's one of the factors that leads to invasive candidiasis, candidemia, persistent infections, and so forth. And on this picture, you can see Candida albicans biofilm life cycle. So if you look on the right, you can see that it starts with the adherence of the yeast cells to the surface, and that could be any device. So it could be CVL, it could be CNS shunt, it could be artificial prosthesis. So once the yeast adheres to the device, the biofilm starts forming. And as you can see on the very right, so you can see that it starts forming first this basal layer of cells that are adherent to the prosthesis or the catheter. And then in the next stage, the biofilm forms multiple layers, so it kind of matures. And then, as you can see on the stage D, if there is an external factor that causes, some disturbance of the biofilm, or the cell mass of the yeast just becomes very overwhelming, what happens is that yeast cells leave the biofilm and start seeding into the new sites, and that can lead to fungemia, septic emboli type of picture, and so forth. So remember, biofilm formation for all Candida species is extremely important. And this is just a picture that shows you the common Candida albicans biofilm associated infections. And as I already mentioned, it essentially can affect any artificial material that is retained. If you have a transient fungemia type of situation, all those devices can get infected and lead to invasive candidiasis. And just for you to remember, on this slide, I put some unique characteristics of certain species. It's kind of the buzzwords that you should remember, not only for the boards, but when you start working as well. So for Candida glabrata, as we discussed, this is the second most common non-Candida albicans isolate in the United States. It's not dimorphic as other species, so it does not form pseudohyphae in the tissue, as we discussed. And from perspective of the treatment, it's known for increased resistance to azoles, especially fluconazole. So you should not be using fluconazole for this species until you confirm the susceptibility. Candida krusei is another important one to remember because it's inherently fluconazole resistant. What it means that if you get a call in the middle of the night saying that this patient has Candida krusei isolated in the blood or sterile site or whatnot, and the patient is on fluconazole, you need to change the therapy right there, right? Candida parapsilosis is a less virulent species. However, it thrives really well in hospital environment. It grows in TPN, so definitely is associated with hospital outbreaks. Candida dublinensis is particularly common in HIV-infected individuals, and it is known to colonize deep periodontal pockets. So it's one of the most common causes of oropharyngeal candidiasis in HIV positive patients. And then going to the right side, I put some unique characteristics of certain species based on their resistance patterns. So when I tell you name fluconazole resistant species, you should keep in mind Candida krusei, right, which is intrinsically resistant, Candida auris, and Candida glabrata, unless you confirm that it's susceptible, right? But you should assume it's resistant unless proven otherwise. And then for Candida lusitaniae, that's a tricky one. So that's the one that has a feature of intrinsic and acquired resistance to amphotericin B. And again, you might get tested on that, so keep that particular species in mind. Not very common, but you should be aware of this particular resistance pattern for this subspecies. And I have a first case, so I briefly read it for you. So we have a 67-year-old man with a diabetes, chronic kidney disease, and recent hospitalization for septic shock. So he's been ICU for a few days. He's been intubated for 10 days, has a central venous catheter, has been on antibiotics for 14 days, and now he has a new fever, hypotension, and tachycardia. His blood cultures are growing yeast with rapid ID positive for Candida auris. Which of the following is the most appropriate initial management? So these are your choices. So start high dose fluconazole and remove central line. Begin liposomal amphotericin B and maintain strict contact precautions. Initiate echinocandin such as micafungin and implement infection control measures. D, switch to voriconazole and report to local health department. And E, begin an echinocandin such as micafungin and discontinue all antibiotics immediately. So what would be most appropriate as an initial step?
B. I think there's high resistance to amphotericin with Candida auris. I think it's C.
Yeah.
I think echinocandins.
Sure,
But would you like ever consider, I know it's not a choice here, but would you consider dual therapy? Until like susceptibilities are back?
So good question, but you don't have it as an option.
No, I know.
Right?
Right, I
Yeah.
would go with C here, but that would be, I was just a follow-up question.
I would say we would still stick with a echinocandin.
Okay,
In the beginning, unless you have extremely unstable patient and maybe you have an internal biogram saying that you have Candida auris that is essentially pan-resistant.
okay.
So I heard B and C. Okay, so the correct answer here would be C. So you will initiate micafungin and implement infection control measures, which means that, yes, you will have to put this patient on strict isolation, contact infection prevention, and infection prevention measures and evaluates what further needs to be done for infection control, right? So this might mean that you need to screen the unit, right? And other patients to make sure that you are not dealing with an outbreak type of feature. So a couple of questions just to think about this case. So what are the predisposing factors that potentially led to this infection in that particular patient?
Non-central line, long hospital
Long
stay,
hospitalization stay,
antibiotics.
ICU,
Yeah, so many risk factors, right? So prolonged hospitalization, ICU. They told us that the patient was intubated, had a CBL, right? All of those would put you at risk for Candida auris. And can you recall what challenges are there for identifying Candida auris in the lab? So I'll briefly mention it, but it might be confused with other species or subspecies of Candida. And as we discussed, echinocandin is recommended as a first-line therapy. Bless you. Again, when you hear of Candida auris, make sure that you notify infection prevention because they will need to implement certain measures in place and potentially screen other patients as well. So just a couple of slides on Candida auris. It was first identified in 2009 in Japan and got its name auris because it was first isolated from the ear canal of the patient. It has rapidly emerged as a serious global public health threat because it can cause life-threatening infections. Definitely, as we mentioned, has MDR features. And again, one of the Candida species that thrives in hospital environments, forms biofilms very well, and can cause outbreaks within the hospital settings. So specifically for the Candida auris, most often it colonizes the skin, specifically axilla, groin, nares. Less often, it likes to colonize mucous membranes. So mucosal infections are not as common with Candida auris. So perhaps when it's isolated from those sites, think about you're probably dealing more with colonization rather than infection. And on this slide, I put the risk factors for Candida auris colonization. So we already mentioned those would be patient-related risk factors, such as you have an individual who's been in the hospital, in the ICU for extended period of time, has received broad spectrum antibiotics and so forth. And then definitely epidemiologic risk factors, such as patient is in the facility with a known outbreak, with a known case of Candida auris. And also, as we mentioned, remember presence of any type of indwelling catheters, especially if not removed, definitely puts you at risk for acquisition of this infection. So 4 things that you're going to remember about Candida auris, that it loves to adhere to medical devices. It thrives in healthcare settings. And because of this, it definitely is one of the non-Candida species that is notorious to cause outbreaks in the healthcare settings. Lab might have difficulties identifying this pathogen. So if you had a case potentially, a few days ago or a couple of weeks ago, and now you have a patient that lab is giving you perhaps a very rare name for the Candida species, don't hesitate to call them asking, hey, are you sure it's not a Candida auris? Definitely can cause invasive infections, and MDR is the 4th important feature of this species. So specifically, on the distribution, initially 5 distinct geographic clades of Candida auris were identified. They're a little different in how they behave and susceptibilities, but again, all of them have features to be MDR. Definitely something to keep in mind. And these are just the key points about Candida auris infections in general. We went over it, so this is just for your review later. So now we're going to talk about clinical manifestations and presentations for Candida infection. And it is divided in 2 main categories. So you might be dealing with mucocutaneous Candida infections, which could be your oropharyngeal candidiasis or thrush, esophagitis, vulvovaginal candidiasis, or a diaper rash. And then the second category is what we call invasive candidiasis, which includes candidemia and your deep-seated or end organ infections such as endocarditis, osteomyelitis, endophthalmitis, and hepatosplenic candidiasis. So we'll go over a couple of examples of mucocutaneous candidiasis, and the first, which we see quite often, is an oropharyngeal candidiasis. So here you see the pictures of the patients with this condition, and you see on it's a picture of oropharyngeal candidiasis, and as you can see, most often you will see this white patches that can be removed with a scraper that present not only on the tongue, but you will see them on the inner buccal mucosa and in the back of the throat. So if you have an appearance only on the tongue, again, ask yourself if you're really dealing with oropharyngeal candidiasis or one of the mimics or the things that should be on a differential diagnosis. In the picture B, you see oropharyngeal candidiasis in the HIV patient. Also remember that it can cause dangerous stomatitis as depicted in picture C, and angular cheilitis, as you can see in the picture D. And that you can see quite often in the patients that are receiving broad spectrum antibiotics or just completed the course. And a couple of mimics of oropharyngeal candidiasis, and we get asked about it all the time, especially on the heme service, right? So white tongue does not equal oral candidiasis for sure, right? Keep in mind things like oral hairy leukoplakia or leukoplakia in general, as well as oral lichen planus. And they all look a little different, but oral lichen planus usually look like very fine, flat, at times reticular lesions. And oral leukoplakia look more like a thickened, whitish, brownish spots that most often are present on the tongue, either the whole tongue or just the sides of the tongue. You potentially can do a biopsy if absolutely needed. A lot of times it's more of a clinical diagnosis and the trial of the treatment. And then of course, if changes continue worsen, then biopsy is often needed. And now we're moving to the second case. So you have a 42-year-old male with a history of HIV who presents to the clinic with progressive adenophagia and retrosternal chest discomfort for 10 days. He reports difficulty swallowing both solids and liquids associated with mild nausea, but no vomiting. No melena or hematemesis, and he is poorly compliant with his HIV regimen. As you can see, he has low CD4 count. As far as you know, no prior opportunistic infections, no recent antibiotic use. He is on antiretroviral regimen, as outlined here. And on his exam, you notice white plaques on the tongue and buccal mucosa that are easily scraped off. So what would be the most appropriate initial therapy in this case if endoscopy shows you white plaques in the esophagus? And in general, even in general.
B.
Bacteriocin, fluconazole, caspofungin, omicafungin, nystatin, and voriconazole. So what is your diagnosis here?
Esophageal candidiasis.
Esophageal candidiasis, very good. And on the same question, so your patient with HIV and esophageal candidiasis fails oral fluconazole after 7 days. So what is the best next step? Switch to itraconazole solution, add topical nystatin, increase fluconazole, start amphotericin B, or begin CMV therapy empirically.
See.
Yeah.
I think you can actually go both ways. You can increase the dose. However, it appears that this patient BMI was low, so most likely his dose was optimal. So you can consider A. I think in the reference, it actually gave me A, so switch to a itraconazole solution. So, and just a couple of questions to think about. What would be the risk factors for developing Candida esophagitis in this patient? And what else would you have on differential diagnosis? And would you consider empiric treatment in this patient before going to endoscopy?
Yes.
Yeah. It could also be HSV, CMV, but
Yeah.
usually you start with empiric therapy, and if that fails, then you do endoscopy.
Great, yes. So the risk factors for developing Candida esophagitis in this patient, as you said, HIV, they gave it away that CD4 count was very low. So that has been shown to be associated with increased risk for Candida esophagitis in HIV positive patients. David, great job on the differential diagnosis. Yes, in appropriate clinical setting, so if you have an appropriate patient with appropriate risk factors and evidence of oropharyngeal candidiasis, you can implement empiric therapy and then assess for response and then refer to endoscopy if needed. If I tell you that you have a patient with dysphagia, right, retroesternal chest pain, but on exam you do not see an evidence of oropharyngeal candidiasis, you potentially can try treatment, but in that scenario, you would probably try to get an endoscopy on that patient as well to make sure that you're not dealing with CMV, HSV. Another one, pill esophagitis is also common, right? So differential diagnosis in that case would be much broader. Yes, so we're pretty good in recognizing HIV, AIDS with low CD4 count as the important risk factor for esophageal candidiasis. However, we do see oropharyngeal and esophageal candidiasis quite a bit in our patient population. So severely immunocompromised patients in general, SOTs, HCTs are definitely at risk. The risk is mostly driven by ongoing immunosuppression, intermittent or continuous steroid use for things like graft versus host disease. Other risk factors to remember would be diabetes, peptic ulcer disease, recent use of antimicrobials and corticosteroids, even in non-immunocompromised patients. The studies showed that PPI use was actually associated with esophageal candidiasis in patients with a normal immunity. So keep that in mind as well. And as we already discussed, if you have a patient with known risk factors and evidence of oropharyngeal candidiasis, it is predictive of esophageal candidiasis, and you can proceed with a trial of treatment before referring that patient for an endoscopy. Yeah. So I tried to find a good table with the treatment options for oropharyngeal and esophageal candidiasis, and up to date had the best table, so here it is for your review. I think we had a small discussion about the treatment of esophageal candidiasis. So as you can see, preferred treatment would be fluconazole, right? And then for the refractory disease, you have initial approach, yes, double up on the fluconazole, especially in the patients that based on the weight that you think they might have not received an appropriate dose. And then if there is no response in 5 to 7 days, change them to either itraconazole or voriconazole. Posaconazole is an option as well. And I'll mention that in transplant patients, yes, a lot of times we do use echinocandin if they do not respond to fluconazole. It's just because of significant drug-drug interactions with the immunosuppressive agents, or if they are on maintenance chemotherapy or agents to control their hematologic disease.
I have a question.
Yes.
What would be the treatment of choice in a patient who has like a prolonged QTC? Like, let's say their QTC is like, 550.
Good question. I think you would probably have to go with echinocandin,
No other
such as
oral options?
mycopungin. I don't think you would have a good option, honestly. Even though Cresemba is
Cresemba doesn't have good
asafoconazole
coverage.
is listed as an alternative option. I'm not sure how reliable agent it is for the treatment of.
Amphotericin doesn't affect the QT.
It does not. Remember that if you have esophageal candidiasis, your treatment duration is at least 2 weeks. 2 to 3 weeks is your range, right? So it would be extremely difficult to give someone amphotericin B for such an extended time, right? Without running into side effects. So I don't think it would be your first alternative. I would say echinocandins, isobuconazole probably would be your first 2 alternatives to go.
The reason I asked that is actually I have a friend who's a GI doc, and she asked me for advice about that. Because she had a patient that was an outpatient. She did a colonoscopy endoscopy diagnosed esophageal candidiasis, but the patient had prolonged QTC and she wasn't sure what to do with this patient. So, yeah, so
That's a good question.
like as an outpatient, yeah.
Don't check the QTC.
Don't check. La 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 la.
With the hardest, just ignore it.
Just ignore it, okay.
Yes, good question. Yes, so now moving to a few slides on invasive candidiasis. And as I showed you in the first few slides, so generally what happens with invasive candidiasis, you first have an overgrowth of candida in your gut, or you have candida colonizing the sites close to your indwelling catheters, right? And then what happens next is there's a breach either in the GI mucosa or the skin, and that's how candida cells make their way into the bloodstream, right? And once it's in the bloodstream, you can have transient or persistent bacteremia that can seed into the other distant sites. So that would be your first mechanism. The second mechanism is more unique to the patients with GI surgeries or intra-abdominal infections such as necrotizing pancreatitis. What happens is in those cases, essentially you have either anastomotic leak, right? or a seepage of your intestinal flora into the peritoneal cavity, right? And that's how you end up with intra-abdominal candidiasis in those patients. We mostly see it at MMH. Once in a while, we would have a case like this. On this slide, you have your standard risk factors that would put you at risk for invasive candidiasis. We kind of went over it a little bit. So critical illness, ICU stay, intra-abdominal surgery, acute necrotizing pancreatitis, your severely immunocompromised patients such as heme malignancy patients, even solid organ malignancy patients that are undergoing chemotherapy, transplant patients, both SOTs and HCTs, underweight infants, specifically premature preterm infants, use of broad spectrum antibiotics, and presence of any indwelling devices, right? Any indwelling devices or artificial material. This is kind of saying the same as I just mentioned. I included this table from the Nature Review because it includes this additional risk factors such as your graft versus host disease, patient profound neutropenia, as you can see on the bottom. And this is one study that I included that was published in 2025 on epidemiology and clinical characteristics and outcomes in patients with candidemia. So this study came from China. And as you can see, in this study, they showed that the Candida tropicalis was the second most common species. But remember, in the US, mostly it's Candida glabrata. In other parts of the world, the distribution is different. So the independent risk factor for Candida infection, specifically fungemia, was a GI surgery. And as you can see here, patients that had candidemia had a quite high mortality of 30%.
Do you think that the mortality, is that high because of the candida itself or because of their underlying comorbidities?
It's a good question. I think it is most likely both. I did not think the study specifically looked, at the correlation of the risk factors, but as you can see here, at the factors that were associated with mortality, right? So they are, even independently, most of them would be associated with mortality. Age, septic shock, ICU admission, other ones that they had fever, respiratory distress, presence of CVL or CLABSI.
Just, it's kind of to come to what you're asking, they presented some data at ID Week talking about what have basically looking at how we have changed our management patients with candemia, right? From fluconazole empirically, and then the guidelines have changed, and now we use in the kind of Candid, but yet our mortality has not changed across the board over 20, 30 years. So despite having better drugs, our patients are still dying at the same rate. So it's probably the patient themselves,
Yeah.
more so than, because the point of the lecture was they would really need to be using in a kind of Candid up front, right? Certain patients, but it was a clinical debate. But the idea out of that was that despite using better agents, our patients are still dying at the same rate. We haven't improved their outcomes. So I think it's the patient population that get Candida, invasive candidiasis. You're just sick.
Yeah, I'm just thinking about our own clinical experience. Generally, if you have fungemia in the patient who is on the floor, and fungemia, which is potentially related to CBL or translocation. But otherwise, the patient is doing well. Those patients generally do well. Comparing to those that would develop candidemia down the line of their ICU stay while, once they've been through a couple of weeks of IV antibiotics, intubation. Yes, I think the mortality in those patients is definitely multifactorial. And a couple of things to keep in mind about the candidemia. Remember that it is recommended by the guidelines that patient with a candidemia has a fundoscopic examination because up to 15 patients with candidemia will develop some manifestation of ocular involvement. Also remember that specifically in neutropenic patients, it's recommended that you delay fundoscopic examination until after they recover their counts because those changes that you're looking for might not be present while they're profoundly neutropenic. In terms of the need for the TEE, endocarditis is generally occurs rare in patients with candidemia unless you have specific risk factors for infective endocarditis. And those would be, pre-existing valvular disease, you have a prosthetic valve in place, history of IV drug abuse, then yes, in those scenarios, TTE is recommended. Another case scenario would be that you have a patient who is not able to clear cultures, right? Definitely endocarditis needs to be ruled out. I will mention this briefly on the diagnosis of invasive candidiasis, and one particular issue that we need to remember is that the sensitivity of blood cultures for retrieving yeast or candida is quite low, right? So we're talking about 30 to 50%. The higher the volume of blood and the more sets you have, you will increase your sensitivity. However, we are talking, they were talking about a blood volume over 60 mLs to increase your sensitivity to retrieve the fungus. That's quite high.
Resets.
At least, yes, they said 2 or more.
Wow.
Resets it.
And you have to have at least 20 to 30 ml in each bottle.
Oh, wow.
Yeah,
Wow.
right.
The lab will hate you, they'll type overfill.
Yeah.
Yes, and the patient might hate you as well.
Yeah.
So that's the first point to make. The second point is the median time of yeast growing in a blood culture is about 2 days. So 2 to 3 days. This would not be, a gram-negative rod that would grow overnight, right? You will need to sit tight and wait a little longer. When this becomes, practical to remember, in the patients with fungemia, what generally happens, we recommend that their CBL is removed. And the next question from the primary team, when would you place the PICC line, right? So in patients with your standard bacterial organism, we would generally say 48 hours, right? Because some patients are really in need for the central catheters. With yeast, again, think twice. You would most likely want to wait 3 to 4 days, or, we say 72 hours when you give okay to place that PICC line. So keep that in mind. And another test that we use quite a bit, specifically at Moffitt, is beta-D-glucan and panchitol. So sensitivity is very high two issues. So it is not specific to Candida, right? So it will pick up some other fungi. So the ones that it is approved for would be, what are the other two organisms?
PJP.
Aspergillus and PJP, right? And remember, it could be positive with other fungal infections, non-mucor, but it could be positive as well. And the second issue that it has a high incidence of falsely positive results, right? So IVIGs, certain antibiotics, patients on dialysis with certain membrane structures. It appears that it is not as much of an issue right now, but again, you want to probably have repeat testing to verify that it's positive. And again, if it's positive, look at your clinical scenario and what is your probability of that patient having invasive fungal infection. So we always want to remove the catheter if possible, give it a holiday before we place a new central line or PICC. So for the treatment resources, I will briefly go over it and highly encourage, if you have a patient with fungal infection, specifically invasive candidiasis, please double check with the guidelines. The treatment is very detailed depending if you're dealing just with candidemia or you're dealing with a specific organ infection. The treatment might be different because you want to think about if the drug that you're using has appropriate penetration, right, into the organ that you're treating, and other appropriate concentrations of the drug as well. So two great resources to use is IDSA guidelines that were published in 2016. Then there are global guidelines that were just published in Lancet this year. So that's another great resource. And of course, Hopkins, Stanford antibiotic guides, concise, but always up to date recommendations as well. This is a table just for you to review and kind of have a visual reference specifically for fluconazole susceptibility on most commonly isolated Candida species. And remember, what are the three species you're going to remember for fluconazole, either intrinsic resistance or resistance that might be acquired? Do you remember?
Cruciae,
Glabrata,
Yes.
and auris.
Okay, auris, very good. Glabrata, remember that fluconazole you can use, but you have to confirm that it is susceptible. What is the one that can have intrinsic and acquired resistance to amphotericin? Very good. Okay. And that's what I mentioned. So echinocandid is a drug of choice, right? You're gonna remember that, except there are three sites where echinocandin is not your drug of choice because of the issue with penetration or drug concentration. CNS, urine, yeah, and eye. CNS, urine, eye. So you have to go with other options on your exam or in real life as well. And this particular paper which was published in Lancet, it has multiple tables on the options. So they're all here for your review. For the duration of treatment, for candidemia, it's 14 days from first negative blood culture. And for deep-seated infections, again, look at the specific guidelines. A lot of times we're talking weeks, potentially months, and some of the patients that continue to have retained material will go on suppression indefinitely. That's for the CNS. And do you think we have like 10 minutes?
Yeah, that's fine.
It's fine, okay, start a little later. So this is the patient case number 3. This is the patient actually we took care at Moffitt, and unfortunately she passed away. So she's an 18-year-old female with the diagnosis of ALL who recently had reinduction chemotherapy. Her course was complicated by neutropenic fever. Blood cultures were repeatedly negative. On the chemistry profile, the only abnormalities that you noted were elevated alkaline phosphatase, ASP, and ALT. 40 days into treatment, the chart says that she had some papular skin lesions, which were biopsied, and tissue culture was positive for Candida tropicalis. She was initially treated with micafungin and then was transitioned to fluconazole. So this patient came to Moffitt to have her transplant, so she came for transplant evaluation. And her vital organ testing revealed these multiple lesions in the spleen, liver, she had right kidney lesion, and she had a nodular lung lesion as well. So just based on this information that is here, what is on your differential?
Disseminated candidiasis.
Hepatosplenic candidiasis, right, or chronic disseminated candidiasis. So she underwent actually both lung biopsy, which was non-revealing, it just revealed sclerotic tissue. But the hepatic lesion biopsy showed budding yeast consistent with Candida species, although the culture failed to grow it. So we did send the species of the tissue sample to University of Washington. It came back positive for Candida tropicalis, essentially confirming the diagnosis of hepatosplenic candidiasis. So the pathophysiology is not very clear, but it's actually very interesting. And kind of in a nutshell, what happens with these patients is induction chemotherapy, prophylactic antibiotics, all of these patients, they have fevers, right? So they're heavily treated with antibiotics. And what happens, you have Candida overgrowth in the gut, right? And you have neutropenia. So at some point, these patients experience translocation of the Candida species into the gut. And first, these organisms, they translocate into portal venous system. And that's probably why most commonly you see lesions in the liver and spleen. And what's important to remember that these patients, I'll advance to the slides, will have positive blood cultures only in 20 to 30% of the cases. So do not look for it specifically in your question because most of the patients will not have positive blood cultures. So kind of the buzzwords or what you're gonna look in the clinical picture to diagnose this condition would be you had a patient with persistent fevers at the time of neutrophil recovery or after they experience severe reconstitution. Right upper quadrant pain, elevated LFTs, and multiple liver and spleen lesions. This is what's gonna make a diagnosis. Most of the times the diagnosis is presumptive because of course doing a biopsy, liver spleen biopsy on these patients while they're recovering from induction chemotherapy, it's extremely challenging. It can be associated with complications. So what happens with these patients a lot of times, we start them empirically on treatment, initially with either ambisome or echinocandin such as micafungin, and then you use fluconazole as a step-down therapy. And the treatment generally continues for months, but they recommend in the guidelines that you continue the treatment until the lesions are resolved, which again, I think this patient was treated for months and months. Chemotherapy and transplant are not contraindicated in patients with hepatosplenic candidiasis as long as you feel they're stable and they've received sufficient therapy. I mentioned it a couple of slides ago. So these patients at times have persistent fevers, which is related to immune reconstitution and hepatosplenic candidiasis. So in those patients, a short course of steroids is actually appropriate and a lot of times is prescribed.
Do you know if for that patient was a carrying scent? Would that be helpful? And since blood culture is only positive like 20 to 30%, other than getting a biopsy, like I don't know if Carius was positive.
So this was before we
Oh,
started
she was before he started
using
Carius. Okay.
curious, but I agree, yes,
Okay.
definitely appropriate. Without, for example, curious and the blood cultures, you can use things like fungital, right? I know some
Sure.
institutions, they have some other blood PCR techniques. So those can be very helpful in these patients as well, yeah.
You'd wanna probably look up the negative predictive value and positive predictive value for carious for yeast specifically.
Mhm.
It varies even for molds, so like it's
Right.
pretty decent for mucor and it's very bad for aspergillus.
Mhm.
So you wanna know what your test, will a negative carious test tell you that this patient doesn't have hepatosplenic candidiasis, right? So you wanna make sure when you're ordering the test, you know what the negative and the positive predictive value of those tests are in specific patient populations because they will vary even across patient populations.
Mhm.
Good point. And the fourth case goes over another very, very common situation that we get called about all the time. Essentially, you have a urine culture positive for Candida. With that. And, this is your typical patient with a couple of comorbidities that receive broad spectrum antibiotic. As you can see, she does have some urinary symptoms. UA is positive for pyuria and urine culture has Candida glabrata. She did have Foley catheter in place, but that was removed on discharge. And the key points here are that you have to make a distinction if you're dealing with a UTI, which means you have symptoms, right? Versus you're dealing with asymptomatic bacteriuria or funguria. If you determine that you're dealing with asymptomatic funguria or candidiuria, the recommendations are very clear that you treat only high-risk patients, right? So in the box here, you've got 3, so very easy to remember. Neutropenic patients, very low birth, infants, which would not apply to our population, and then patients who will undergo urologic manipulation, right? So aside from that, you try to remove indwelling catheter if it's possible. You try to exchange it if that needs to remain in place. But again, the treatment is not indicated in most of the cases. And then the second key point here to mention is on Candida glabrata. So remember, it's one of the pathogens that is not always susceptible to fluconazole. The issue is that micafungin would not be your drug of choice to treat UTI, right? So if the patient is stable, it's very appropriate to wait on the susceptibilities on the Candida glabrata, and then if able, you're going to use fluconazole. And then if you're not able, then, you know, sometimes you have to use something like amphotericin bladder irrigation. Again, echinocandins in the settings of a UTI. It is very questionable.